This is Blood and Cancer, the official podcast of MDedge Hematology/Oncology, where we discuss the latest research, treatment considerations, and other issues related to hematology and oncology. Welcome to this podcast. I'm your host, Dr. David Henry. You're listening to Blood and Cancer, and I'm delighted this week to be speaking with Dr. Stephen Pergam, the Associate Professor at the Fred Hutchinson Cancer Research Center, also the Infection Prevention Director at the Seattle Cancer Care Alliance. Dr. Pergam, thanks so much for joining us today.
Thanks for having me. Appreciate being here.
Well, you're very welcome, and we appreciate you joining. We're talking, who doesn't know about the NCCN? Our listeners are typically practitioners in hematology and oncology, and so as we mentioned a moment ago, I tend to pull this up sometimes. The patients say, well, let's see if this is still the right recommendation. What's the NCCN say? And I sit on one panel for Kaposi sarcoma, so I know there's a lot of work. So appreciate all you do. And who hasn't thought about what to do in the COVID era and the vaccination response, this incredible technology, the ones as we record this in February of 2021, the Pfizer and Moderna in the US are messenger RNA based, maybe some others coming. But of course, the NCCN stepped right up, came out with version 1, dated, unless you correct me, January 22 is the current version. And so I thought we might do is step through them and talk about some of these recommendations and who gets what. And to begin with, prioritization. You know, I have a patient of mine said a few weeks ago, this whole vaccine thing, it's been all about breakthrough and not follow through. I said, boy, that kind of sums it up. The age criterion that a lot of them use nationally kind of changes a bit as you get to patients. So maybe you could comment, how did you, NCCN, prioritize, and maybe mention a few of those items?
Yeah, thanks. So first of all, again, thanks for having me on, because I think I'm speaking for a lot of different people who contributed to this guidance document. I think what's really difficult about prioritization when it comes to making decisions about this, and something that we all struggled with, is I think that the general practitioner on the front line wants to be able to say, X patient gets it before X patient. But that's actually not very easy to do, particularly with the prioritization schema that exists, both from the ACIP, from CDC, in terms of the tiers and prioritization schema that they have, but also secondarily what states are doing, because an individual state may be very different than another individual state. So as many people know, in Florida, sort of the older population was offered vaccine very early in the process, where many states were still in the 1A categorization, which was healthcare workers. And so I think that makes the challenge difficult to come up with a guidance document that's going to serve everyone. So you have to be sort of in a larger system, more broad scope, so that individual institutions could look at this guidance and come up with their own personal ways to look at this, because one cancer institution may get 5,000 vaccines to deliver and another may get 500. And so that prioritization may be varied. So the way that we really thought about this was, who are the most at risk for developing severe COVID complications? And that included primarily patients who were getting active chemotherapy or were about to receive active treatment, or those who had just finished active treatment. So that was the group that sort of got early prioritization. And then in addition to that was similar things that I think we think about in prioritization is risk factors associated with that, which would be age, comorbidities, et cetera, that might be associated. So that was the way we wanted people to think about it, was to take into consideration the high risk, those receiving treatment, and then beyond that, potentially those others straight out possible.
I thought that was awfully, just as you delineated, very nicely done, because you hear, I'm in the Philadelphia area, and some of the counties just said 75, and you can have 75s that play tennis and 45-year-olds that are hardly able. As you said, age, comorbidity, and I noticed social demographic factors that include poverty, limited access to care. Those patients, patients are getting sicker easier. So that was included as a priority item, which was really nice.
Yeah, and I think that was really intentional, because we have really seen in the rollout with vaccines that many high-risk groups that are disproportionately affected by COVID-19 have more severe disease manifestations and make up a large proportion of those who are hospitalized are not the people who are getting vaccine right now. And that's been something that I know nationally has been a major effort, certainly an effort within our state to improve. And so one thing I think cancer centers can do is they can sort of look for ways to incorporate these populations into their strategies, so that we make sure that we make specific efforts to reach out to these communities where risk is higher. And that can be all kinds of issues. That can be things like language barriers that can be quite challenging. It can be patients that maybe don't have easy access to a location where there is a large vaccine site. So it's quite diverse, but we really want to really target racial and ethnic groups that we know have been primarily associated and other high risk groups in that situation.
Yeah, so nicely done. So to summarize that, active treatment are cancer patients. Of course, the NCCN is speaking to that. And then subsection 2, age, particularly over 65, comorbidities, which many of our active cancer patients have. And then that third line, social and demographic factors that include poverty, limited access to healthcare, underrepresented minorities. Really, really nice. Okay, so then we'll lead off with table 1. It'll be on our website, mdedge.com/hematology-oncology. We'll put a URL link to version 1 of the NCCN. Table 1 starts off with who are the recommendations for cancer patients? And so it goes right to the top, those stem cell transplanters, no surprise coming out of the Fred Hutchinson Cancer Center in your area. So allogeneic, autologous, and cellular like CAR T cells, these people, I kind of think of them as being reborn. So their immune systems are just trashed and then they're reset. So what's the recommendation to vaccinate there?
Yeah, so obviously these are very high risk groups. There's a recent publication that was put out by the American Society of Transplant and Cellular Therapy in the Lancet, which described mortality rates of around 30% in some of these high risk transplant populations, and so a very high risk group. So part of the decision making in this was to really target them at an early phase. So we know that immune systems recover in a delayed fashion within these populations. But there is data with other vaccines that response rates can start as early as 3 months post-transplant. And so targeting patients in that category can necessarily provide some protection. And so that was the goal within the guidelines, was to try to get vaccine as early as possible while there is ongoing circulation in our communities. So that was sort of the earliest phase, as early as 3 months post. And I think individual centers can look at this. Some look at factors like CD4 counts and others to determine when they want to give it. But we wanted to give some general guidance based on other vaccines and when we knew the earliest that might be possible where patients would have benefit.
And it's a timely recommendation because I know you have a lot of these patients, and I have some, mostly autologous, and they're asking. I had mine 3 years ago with my most recent patient, and I said, I think you're okay. So here we have a nice guideline with some data behind it, at least 3 months or within 3 months. So next,
and again, just to interrupt for a second. So I think it's key that the guidance and the data that's there is really about other vaccines. We don't have data for this, and so a lot of these guidance are summary recommendations based on best practices for other vaccines, particularly things like influenza vaccine. But we really hope that there'll be additional data for other. I think there's a lot of interest in doing studies. There are a number of centers who are doing work around this. They'll be looking at timing of vaccine, adequate T cell responses and antibody responses to better help us to clarify some of these recommendations. So these recommendations are going to be updated on a regular basis to make sure we incorporate those.
That's
details.
The beauty of the NCCN. It's just a living textbook.
Exactly.
As an aside, I'm sure you've heard, get your vaccine, don't take the NSAIDs. If possible, you can do Tylenol, Benadryl. That actually, when I interviewed the inventor of the mRNA, the Moderna and Pfizer, which we have in the States, that comes from flu. That comes from flu processing vaccine. And so we actually don't have that data yet, but it's a good extrapolation for the COVID-19. Okay. So then one click down, hematologic malignancies. And so we're thinking here, the cytotoxic chemotherapies, in particular, this line item mentions AML. And if you want to discuss what the recommendation is there.
Yeah, so This was probably the most challenging area because this is a particularly high risk group when their counts are very low. We don't want to miss opportunities to vaccinate patients, but we also don't want to give vaccine when the benefit might be very limited. And that would particularly be patients who are neutropenic and have really no cellular recovery immediately post chemotherapy, and particularly around induction, intensive induction. The way that we focused on this was to delay until there was at least absolute neutrophil count recovery was the primary focus in those patient populations. And then when you looked at patients that, we've seen a number of us take care of these patients that have AML or some other marrow failure where their counts really never recover while they're maybe, waiting for a transplant or waiting for some other intervention. We would just say vaccinate those patients when available and hope they get some response. And then for those who are on long-term maintenance therapies, like a patient who is a myeloma patient or a patient with CLL, we would say whenever available. So not trying to target around when their therapy is given, but really try to give it whenever the vaccine is available to them. So if they're eligible as a 70-year-old with multiple myeloma in their state, we would really recommend they go get that as soon as possible if they're on maintenance therapy.
So would you tweak that at all? Let's say the CLL patient, I can see the BTK inhibitors, therapy, whatever available, but sometimes we'll fold in a CD20 antibody. And this came up at ASH. Down go your B cells make antibody. How can you expect them to make antibody? What's your thinking or the NCCN on the CD20 antibodies, of which there are a couple?
Yeah, I think we've basically said give it, even with Rituxan and other CD20 antibodies, partially because there is actually data in influenza that vaccine responses, although not all antibody mediated, there may actually be some T cell responses that are quite important. So CD8 responses against certain viruses could be, as important or as important as antibody responses. I mean, I think the way you really need to think about antibodies is yes, they are important, but they're really a surrogate marker for vaccine response. There's a whole panoply of immune responses that happen during vaccination, and so it's what we often look at as a marker for someone's response, but it's not always predictive of how protected people are. So I think that was important to us to really say, let's vaccinate these people. And again, I think we want more data as this comes out, but we felt like even a small benefit or potentially a T cell response might be helpful in those patients who do have B cell issues.
Yeah, it makes sense. I like your language, small benefits, some benefit to prevent you getting infected or infecting others can make a difference.
Yeah, and I think really where these vaccines are most important is we don't know as much about preventing infection or infecting others. We think that will happen. We just don't have that data yet. It's beginning to emerge from some data that's coming. There was a recent report out of the Pfizer vaccine that's suggesting that's true. But really where the big benefit is in preventing hospitalization, really severe pulmonary complications, and ICU admissions and death. And if that's really what we can prevent in these populations, then those are critical pieces too. So I think that's a real benefit of these vaccines is if you can keep your patients out of the hospital, then that is a big win for everyone.
So true. I think it's maybe the Johnson & Johnson or AstraZeneca or both, you hear effectiveness 65%, you go, oh, wow, I don't want that. But they were highly effective in keeping you out of clinic, out of hospital.
That's right. And that's true for the mRNA vaccines too. I think really what the mRNA vaccines do is they prevent COVID-19, which is the complication, the infectious disease manifestation of SARS-CoV-2. So I think that's where you're seeing the major benefits of these vaccines. And the transmission and questions of infection, I think, are coming, and I think there's going to be benefit. I just don't think it's going to be 95% like it's been with those major complications that we're seeing.
Could I take a small interject point here with regard to antibody? I'm sure your patients, like our patients, say, I had COVID or I had the vaccine. I want to get my antibodies tested because, then if I'm antibody positive, I'm good. Is the NCCN going to tackle that? Because that's going to come up as more and more of the world gets vaccinated.
Yeah, so I think the question of do you vaccinate prior to try to vaccinating someone? I think the answer right now is no. there is data in the trials that people who had previous COVID-19 that they were able to identify by. They've enrolled in the trial and they were found afterwards to have antibodies, were able to mount a response and did not have a robust immune response to primary infection. There's some data now that maybe suggests that maybe people who've been previously infected might have more prominent symptoms with the vaccine, some more side effects from the vaccine, but not dramatically so. And I think that work is ongoing. But I think the problem that you find is if you use the antibody as a tool, the antibody has some big limitations. So we know that over time after a primary infection, and we've seen this in our own employees who were infected, they lose antibody. So just because you have initial antibody doesn't mean that that antibody will still be there at the time when you're thinking about deciding to do a vaccine or not. It's another big step, and frankly, it's a barrier to getting vaccine. It's kind of like asking what your platelet count is. If you say, let's get a platelet count before a vaccine, then that's a test, and then you have to wait to get the vaccine. So I think it's a step that we don't really want to do, and I think at the moment there's no data that suggests that's necessary. On the other side, the other question that's going to become interesting as time goes on is, when do you test for antibodies post-vaccine to assure that someone's had a response? Because everybody wants to know. We had some patients, actually, interestingly enough, who these needles are pretty small, and you may not get a lot of symptoms after your vaccine. It may be pretty benign. And we've had some patients wonder, like, did they actually get vaccinated? And they wanted an antibody to prove it. But that's not recommended at the moment either, because again, we don't necessarily know what to do with that information. So let's say you get 2 doses of the vaccine, at your 28 interval for Moderna, your 21 for Pfizer, and afterwards, 2 weeks afterwards, you get an antibody and you don't have a response. Does that really mean that you're not protected? Or again, is this more a reflection of the fact that maybe you just didn't produce as strong of a response? It's hard to know because we don't have enough vaccine to consider a 3rd dose. There's been no data on 3rd dose. So I definitely have been telling people when they ask this question to not do that.
Yeah, I tell the same thing to patients. I'm wondering in my mind, though, 6 months from, so I've had my 2 shots, you've had yours too, I suspect. 6 months later, would you check an antibody test? What does it mean? I suspect these trials are ongoing. This data is evolving. But I'm recommending, I don't even think we have a uniform antibody test at the moment.
That's exactly right. That was the other point that I think is really important, is that if you get certain tests, you can get a nucleocapsid antibody, and the nucleocapsid antibody is a better test for primary infection. It's really high and has a high sensitivity at around day 21 after infection. But when you look at the spike protein antibodies, they're varied, and we don't really have, Pfizer, I think in their trial used a proprietary antibody test that is not available. Moderna used one that is more available commercially, but again, it's not as though these are things that people necessarily know when they're ordering this antibody. So if you are ordering this, again, which I don't recommend at the moment, make sure that you're ordering the right one, which would be the spike protein antibody specifically.
Very good. Good to know. So then clicking on down to our final line of recommendations, solid tumor malignancies, which I suspect most of the audience is involved with, the regular dosing, cytotoxic and targeted therapy. So I see there's a line down the right side on timing, when vaccine available. Any thoughts similar to the high dose on waiting for that nadir to be over, or just with regular dose chemotherapy, go ahead?
Yeah, I think a lot of times, with this, it's a little bit harder to predict, because coming up with a summary recommendation for this is imperfect, because our treatments for cytotoxic chemotherapy for most of our solid tumor patients, they don't have the levels of profound neutropenia that you often see in those receiving leukemia therapy, as an example. So the thought is they're typically transient. They might be 5 to 6 days. That, if you have somebody who's usually going through that period, they may not feel great anyways. You may not want to give the vaccine at that time point, but we're really saying it is feasible. So just give the vaccine when you can in those individuals. It may be that they're at your center at that time frame, and that's the ideal time for them to get the vaccine. Use that as a tool as well. So we wanted to be somewhat less restrictive in that particular group, because they're not, that immune suppressive level is more of a transient decrease and is not sustained as though it is within the leukemia population.
And those regular dose chemo, okay, for solid tumor.
Yep.
Now, one more line down. This is a great one. The checkpoint inhibitors. So I can work out in my head that
Mm-hmm.
maybe if I've
Sure.
just turned on this patient's immune system, this person is now ready to make a nice, robust antibody response as opposed to worse. Any thinking there?
Yeah, so there's been questions about, does this boost the response and could this be a benefit for patients? It also could mean they have more side effects, which could be a negative. And right now we don't know, so we just said caution with it. Just keep an eye on these patients and report any adverse side effects. I haven't heard specifically of that being reported to date, and I keep pretty close look on the literature, but something that is one to keep in mind. The other group in solid tumors that I think is important to call out specifically is a group that maybe is not as high risk, unless they have other comorbidities and age-related complications, are patients that are on primarily hormonal therapies. So a breast cancer patient who is just on tamoxifen, as an example, or a prostate cancer patient who's receiving hormonal therapy only, who's not immunosuppressed with additional chemo, might be a lower risk population than, say, a patient who's got colon cancer who's receiving treatment. And then additionally, anybody who's getting surgery, we were a little bit careful about, this surgical question, because what we didn't want was someone to get a vaccine like the day before their surgery, develop a fever because of the vaccine, or have some side effect that would then delay their surgery from happening. So we really wanted them to be thinking about not immediately prior to surgery, and probably for a week or so after surgery, to delay getting their vaccine.
I noticed that in the recommendation. Separate date, few days from surgery. So it was not so much the immune response, it was not to confuse the issue.
Correct. Because you can imagine a surgeon in the COVID era, you have a patient who gets a vaccine, they come in the next day, they have a fever. Everyone's going to be like, hey, I don't know what this is. You don't want to take them to the OR. You want to wait and see what happens. I think you need to be cautious that we don't harm patients in that way by giving them vaccines right before they
and this will come up because your CVS calls you and says, we've got it, it's for you tomorrow, and your surgery is the next day.
That's right.
Makes perfect sense.
Yep.
Why don't we, it's very clear and very nicely done and laid out again, version 1 NCCN website will have this as current as January 22. We finish up by taking advantage of, you're the infection prevention director. So there in Seattle, how are you rolling out the vaccine, for example, to your center's cancer patients? And I suspect you're probably involved with county and state as well. How are you doing it there?
It's been challenging, as you can imagine. So we followed state guidelines, which the initial guidelines were 1A, which was healthcare workers. So we've developed a whole site where we were able to get not only our clinicians and frontline staff, but also members of our community to come in and get vaccinated at our site, who were healthcare workers, dentists, and nursing home workers, et cetera. And as we've gotten into what is considered this B1 group here, which is 75 plus, 65 plus within the state of Washington, we've been able to bring in more of our patients. It's all about vaccine allocation, though, because in certain places, they've moved a lot of vaccine to central repositories and central large vaccine sites. So they've shifted a lot of vaccine to those within the state to allow more access points. And initially, it was all in hospitals. And so now you're starting to see a shift away from that. So, our clinic it's been sort of all over the map. We might get 5,000 doses to give one week, and the next week we might get 500. So it's just hard to know what we're going to get necessarily. I think that will get better as the pipeline gets better and there's more clearance. This is not anyone's fault. It's just the process of getting these vaccines and the production lines, all of the challenges with the winter weather and all the other things that play roles. But what we try to do, and what we're really tasked with doing by the state, is a couple of things. As one is, they don't just want us to target whenever we get vaccine just patients. So we're also targeting our community members that are in those high-risk groups. So we sort of split our vaccine into groups of those we target our patients. We also target our community. And we also, in the process of targeting our community, really also try to focus on family and caregivers of cancer patients to make sure that they're included. We can talk about that in a second. And then additionally, we are spending some time and working with our our high-risk communities to try to give some vaccines and to support those communities and making sure that we can give vaccine to those high-risk groups. So it's kind of a big combination, and I think we're all of the hospitals that are in our area are really trying to sort of bite off all these different groups. And my bet is that as we're going to be getting to what is called the B2 group, which is people with more chronic illnesses, those who are sort of more essential workers. When we get into that group, that's going to be a large portion of our patient population. It's going to be much more challenging to support everyone if we don't have enough vaccine, and we hope that that will continue to get better. But it's been hard.
Well, just as you said, I mean, it makes perfect sense. The active cancer patient, you're
Mhm.
going to get him or her in, but there's
Yeah,
a caregiver, there's a family,
yeah,
each can affect the other.
mhm,
And I heard you say, just go right down the prioritization list. Number one is the cancer patient, but number two is age, comorbid. I think comorbid is so important. And
mhm.
then the social demographic is a group which is poorly health cared. And
Yeah,
so they're much
yeah,
more susceptible,
mhm.
and they may be the caregiver. So
Yeah,
it sounds like
yeah.
you're splitting that out and trying to get both groups, the cancer and the non-cancer, in.
Yeah, I mean, if you think about how these infections work, our cancer patients, um, in general, have been super careful. I mean, they're terrified of COVID when COVID came. They were staying at home, they were masking, they were doing all the right things. But somebody in their family has to go to the pharmacy and get their medications. Someone has to go to the grocery store to get their needs. Some of them live alone, obviously, and have to do that themselves, but many have caregivers and family that support them. And the problem is that if they're out there doing these things and they're not protected, what ends up happening is if they get infected, household transmission is one of the most efficient ways that COVID can transmit. Households don't have good air supply in the sense of frequently exchanging. You can't wear your mask all day at home. They often sleep in the same bed. It's very difficult. And data does suggest that that's one of the primary modes of transmission. So if you can protect family members around that individual, you can decrease the rate of transmission. And it makes intellectual sense because if you know a cancer patient's not going to respond as well, but a healthy household member may have 95% protection, then that really does help to
You've helped
prevent
your patient.
transmission to them. Now,
Good.
we don't know about transmission yet, but we think that that data is going to be true, that these vaccines are also going to decrease infection and transmission. And if
Makes
that's
sense.
true, it will really help protect them. And that's actually a strategy that's been described. It's called cocooning, where you vaccinate everyone sort of around the high risk individual, and really well demonstrated in neonatal intensive care units where that kind of work has happened. So I think that's a strategy that I think is really useful. It's just when there's not enough vaccine, you focus on the high risk individual. When there gets to be more vaccine, we can start worrying about that entire structure around them.
Oh, it makes perfect sense. Well, I've explored all the issues I wanted to cover, unless I've left something out you wanted to mention. I think we're done a very nice job of covering the issues.
Yeah, thanks. I would just want to mention one other thing that's come up that I think we'll probably be adding. We're going to be meeting in a couple weeks to do an update. One of the issues that's come up is breast cancer patients and others who've had large lymph node dissections. One of the things that's interesting is how T cells move through your body is obviously through the lymph nodes. And that lymph node is often the axillary lymph node, right? Axillary
Mhm.
lymph node group. So what we would suggest is that people who've had breast cancer surgery, had axillary nodes removed, or for that matter, have lymphedema on one arm, would be to choose the other arm as the location for vaccine. Because if you don't have lymph nodes, that response may be somewhat tempered. We don't know that, but that's just theoretical. And so we think that choosing the arm where those lymph node dissections haven't occurred may be beneficial.
Isn't
So
that interesting?
I'll be bringing that up as a topic. And there's some groups that are talking about this as recommendations who work in the breast cancer space. So I think
That's
I would keep
very,
that on the radar.
and I'll just throw in, we've had a direction from our mammographers in our women's health at
Yes,
Penn
that's right.
to avoid mammograms routine within
Hmm.
4 to 6 weeks of your vaccine, because you may get swelling under the arm from the side of your vaccine. So
Yeah, yeah.
another simple thought.
Yeah, and another reason to be cautious and be educating people about that. I have had a couple of colleagues who've developed pretty significant lymphadenopathy that's
Mhm.
been not necessarily painful, but really uncomfortable. And so for a breast cancer patient, I think that can be really scary. And we don't want to see people going to surgery for what are essentially vaccine-related complications.
COVID lymph nodes. Yeah, clearly.
That's right.
Well, I can't thank you enough. I've learned a lot, and I want to remind our audience we've been listening to Dr. Stephen Pergam, Associate Professor at the Fred Hutchinson Cancer Research Center, and also the Infection Prevention Director at the Seattle Cancer Care Alliance. Dr. Pergam, thank you so much for joining us today.
Well, thanks for having me, and good luck to everybody out there. Keep track of the updated guidelines. We're going to be working on an update soon.
We will, coast to coast and everywhere in between. Thanks so much.
No problem. Happy to be here.
Blood and Cancer is produced by MDedge. Our editor is Jen Smith. All MDedge podcasts are produced by Executive Editor Kathy Skarbeck, and I'm your host, Dr. David Henry.